so lovely to have so many people here from all over the place.
I
Welcome.
know. Where are you, Ash?
I'm currently in Montana where it is hardcore snowing. Let's see if I can
So
show
crazy.
everybody. This is what's happening outside of my window right now.
Oh my gosh,
It
it's
is not
crazy.
summer. Yeah, we've entered winter. It's not even fall anymore.
Well, I'm in Richmond and it was like 80 degrees here today. So
Oh
it's
my
like
gosh.
full summer, humid, everything crazy.
Lucky you. I would take that right now
I
for
have to
sure.
say, I do feel pretty lucky.
Well, welcome everybody. Yes, jealous of the snow. Emily, if you're someplace warm, I'll trade places with you. My name is Ash Spivak. Natalia, you want to introduce
And
yourself?
I'm Natalia Hills.
And we are both birth doulas. And also the authors of the book Why to Know and Tell Me This: The Doula's Honest Guide for Expecting Parents. I am also the co-founder of All Bodies, which is a digital health and healing club, membership-based platform. And I also train new doulas with Doula Training International, which has been really fun and exciting. Natalia, do you want to add anything about yourself?
Oh my gosh, yes. I'm just getting our book
Oh,
to show our book to everybody. But yeah, I'm also a doula, have been a doula for 6 years. Ash and I started around the same time, so I always ask her, how long has it been?
but I have no
um,
memory, so I couldn't
yeah.
tell you.
And now we both used to live in New York, but now I live in Richmond, in Virginia. I have been here for about a year. And I have a daughter, a toddler. And yeah, we wrote this book. It came out this spring. We've been super excited to share it. And so a lot of the things that we're going to talk about today are actually included in our book. So if anybody wants to, get it afterwards, it's a great tool to have, we think. Um, but yeah, so the way we are going to do this tonight is we're going to be here for about an hour. And we're going to start by just going through some information that we want to share with you as it relates to your rights, birthing in a hospital, and some of the things that we think you can do to make the experience feel safer and more comfortable. And then that's probably going to take us about like 20 minutes or so. And then we're going to leave the rest of the time to answer your questions. So if you have any questions, just hang on to them. And then once we're done, kind of like talking through the main points we want to share, just put your questions in the chat and then we'll answer them in the order that they come through.
Sorry, just to correct that, don't put the questions in the chat, put it in the Q&A
Oh,
underneath. That way we can not lose the questions as they come in on the chat.
okay,
You
yes,
can feel free to use the Q&A box as questions come up as we're talking through things, and we'll just address it at the end.
exactly. Yeah,
Oh,
so
let's dive in.
cool. Anything else we want to say, Ash, before we
No,
start?
let's do it.
Okay, so we like to kind of like take a few moments together just before we start to kind of like, try to quiet our minds, like put them on mute for a couple seconds and then just settle in to what we're gonna do here. So if everybody can join us, just get cozy, make sure that you're comfy, that your spine is sitting up straight, that you fix your pillows, close your eyes. And then if you're pregnant, feel free to put your hands on your belly. That might feel nice, or just put them on your lap, wherever is comfy. And so we're just gonna take a few deep breaths together. So as you inhale, let your belly expand. And then as you exhale, let your belly contract. So we'll do it together. So take a deep inhale and then a deep exhale. And then twice more, just like that, as you settle in, deep inhale. And then deep exhale. And then one more time, deep inhale. And deep exhale and then just let it all go. And when you're ready, just open your eyes. And yeah, we'll get started. So Ash, we're gonna share the presentation, right?
Yes. Do you want to share your screen?
Yes. Let me see if I can figure out how. Sorry, I should have checked how to do this before.
All right. Do you want me to do it?
Yeah.
Okay.
Okay, there we go.
Let me see. Okay. So what we're going to be focusing on today is the experience of birthing in a hospital, your rights as a birthing person, how to advocate for yourself throughout the process, navigating some common interventions, and just overall how to feel safe while birthing in a hospital. So let's start by breaking down your rights, because if you're anything like us, we had no clue that we had actual rights as healthcare consumers here in America. So Nat, do you want to bring us through some of the key components of our rights as birthing people?
Yeah. So just a quick note to say that these are not the only rights that you have. Obviously, there's a lot of them. We're including here the main ones that we think are very important for everybody to keep in mind. But you have a lot more rights than what's outlined here. But to start, we'll talk about individual decision making, which is something that we talk about a lot. So if you've been following us or have read our book, you know this is something that we think is very important, because it really, speaks to, obviously, the fact that you are an individual and that you are the birthing person, that is going to be making the decisions for yourself and your baby, and that you are the one that knows the most about your body, your experiences, your history. You have all this information from being throughout all your life that nobody else has, outside of you. And you're hopefully working with a provider. We'll get into details about how to choose the right care provider and make sure that who you're working with is the best care provider for you. But you're hopefully working with somebody that you really trust, and that you have a good relationship with. But even assuming that's the case, you still have a ton of information that they're not going to have. So as you wait in the process of, like, coming into labor or during labor, even postpartum, all the decisions that you have to make, and as you consider your options, it's important to keep in mind that what the people outside of yourself, the people that are taking care of you, are suggesting or advising is only one piece of the puzzle. You are the only one that can kind of put all the pieces together, because you have the information about yourself that nobody else has. Um, so that's kind of like a little bit about individual decision making and why we think it's so important.
Mm-hmm.
Anything you want to add, Ash?
No, just that no, I think that's great. Yeah, I think the one thing just to consider is that, practitioners are working from a public health standpoint oftentimes, right? They're obviously looking at your labs and helping you navigate the decisions you need to make, but all of our research studies are based on large populations and can never consider unique traumas. They're looking for they're studying one particular part of the equation. So we're not always given the full picture from that, and that's why it's so important to center yourself in the data. So here's just a brief overview of some of your rights. Your right to bodily autonomy. That means that you have a choice as to what happens to your body. By law, your baby is considered part of your body while they are still inside of you. So that means ultimately you are making choices for both you and your baby. Your right to fair and equal treatment speaks to that, regardless of your race, gender, identification, any other factor, we are all supposed to be receiving fair and equal treatment. Obviously, if you look at our healthcare happening in practice. But again, just reaffirming what our rights are and the type of care that we should be receiving is vital in then being able to choose the providers who will actually give that to us and then make some cultural shifts because of consumer demand. And then your right to informed consent and refusal. And what this means is, in the same way that you're supposed to be saying yes to the things that are being offered to you, you can also say no. And there's a big difference between consent and informed consent. In informed consent, you are supposed to be informed of the situation, being given the pros and cons or the risks and the benefits of the situation that you are in, and then supported together with your practitioner to come to a conclusion of what the next best step might be for you. What it does not look like is them saying, we need to schedule an induction on the 24th of October, right? That's not informed consent. That's someone telling you what to do. So is that clear? If people want to put in the chat, if that distinction is clear, that would be helpful. And I'm going to lower my, is it not presenting anymore?
No.
All right, let me go back.
I'll just add that, in that process of going through the informed consent and refusal, as the doctor informs you, based on the evidence of, what's happening with your care, and, the second step to that is they advise what they think you should do. So, you should be induced, or you should, whatever, have surgery or get an epidural, whatever it is that the situation and the advice from the care provider is. That's kind of like the second piece of that puzzle. And then the third piece is like that they have to support that decision that you make, regardless of the fact if it is what they advise or not. So, my doctor can tell me, I think you should be induced, and I can look at all the information and then use my individual decision-making process to say, okay, I'm not ready to be induced right now. I need, more time or whatever it is. And so what's very important to keep in mind about that is that as a care provider, even if your patient is going against your advice, they still have to support that decision that you're making. They cannot refuse to take care of you or keep, being your care provider because you're refusing their advice. That's illegal. So it's just something that's very important to keep in mind.
Totally. And just for the record, it's also illegal for them to perform interventions without your consent at all. Meaning, without asking for permission to do it first. What do you have another example, Natalia, that you can give?
I mean, it does speak to like the first right that we listed, which is the right to bodily autonomy. Before anybody touches you in a hospital setting, you have to consent to that touch. Like, even if it's whatever it is, an IV from a nurse, anything that they're doing, before anybody puts their hand on you, you have to consent. And in order for you to consent, you should be able to, or you should go through that informed consent and refusal process that we just outlined.
Cool.
The last thing on this slide was just to check your Bill of Rights, because depending on the state where you're in, that Bill of Rights might change. So as I said before, your rights are not only these rights, there's like a ton of rights that you have just by entering a hospital as a patient. And they change a little bit slightly depending on where you are. A lot of times they're even posted on the rooms in the hospital, or like in the kind of like welcome area. So it's just something to be aware of. That's important.
And it's good to know that hospitals have, how do you say, ombudsman? The funniest word
I have
ever.
no idea how to pronounce that.
Basically, they're if you feel like an abuse has happened within the hospital, that's who you go to report it to.
And then the last thing I want to say, just before we move on, is that usually when you first come into the hospital in labor and you're being admitted to the hospital, you sign a consent form that outlines that you're giving the care providers and the hospital consent to treat you and your baby. However, that does not mean that you're giving them consent to do everything. You still have to consent every step of the way as things happen. So you still have to consent for that they give you an IV. You still have to consent that they give you Pitocin. You still have to consent that they
Break
whatever
your
every
waters.
step of the way.
Yeah. And you have the right to take your consent back, right? At any time as well.
Mm-hmm.
You can always say no. Okay. So oftentimes, it can be tough when you are already in labor and, you're vulnerable. You're contracting, you're in a gown, right? There's a lot going on. And so we just want to talk briefly about how important it is to find the right provider to be working with and to remind you that with COVID now and in general, the further along you get, the harder it may be to switch providers, but it is always possible. And that remembering like overall that your provider works for you, you hire them, you are their boss. So just some questions that you can ask yourself to kind of see where you're at with your current practitioner. You can ask yourself, do I feel listened to? Do I trust their clinical advice? Do they include me in conversations around my body? Do they ask me questions? Do they ask for permission before they touch my body or do any procedure? Do they explain a procedure before they do it? Do I feel like they push me into things? Do they try and suppress my worries by saying things like, you're fine, or just don't worry about that, or we'll talk about that later, instead of trying to understand where your worry is coming from or give you information that can actually put you at ease? Do you trust that they'll advocate for you? And do you feel like they're around to support you in the postpartum period? So just some things to consider.
This is such an important slide because just, if so many times people ask me like, what is the main thing that you have to do when you're pregnant? Like, what's that big decision that you have to make? And I always say like finding the right provider for yourself. That's so key. Like it determines so much what happens and how it happens. So really just kind of like take a mental note of this. We're happy to share these questions afterwards too. So that, you can really make sure that you are in the right hands. Okay, so then talking a little bit about prepping for advocacy, like another big piece of the puzzle obviously is who is part of your team. So we always recommend that you hire a doula. We know with COVID there's a lot of new restrictions and a lot, maybe a little more hesitation from people to invite more people into their pod space, because of risk of infection. But a lot of doulas now are doing virtual doula services, offering virtual doula services, including us, actually. We'll talk about that later. But so that's an option if you feel hesitant about having someone, present with you in the room because of COVID. But doulas we really are, we've, we do so much work at hospitals that we're very familiar with how things happen and why they happen. And so we can be really good advocates for you and to kind of help you navigate things as they happen, so that you feel a little bit more like informed and more ready to kind of like, speak up or ask the questions that you want to ask, or get more time to make decisions, things like that. So a doula can be a really like important part of the team. But even if you're not hiring a doula, another good point is to make sure that your partner, if you have a partner, or whoever is going to be there with you, hopefully you'll have someone there, it's on the same page with you, knows what you want, knows what you need to feel safe, and knows what you need to be heard or to speak up. Hopefully this is someone that you trust and that knows you really well. And it's important for you all to come together before birth to kind of like discuss how, what are the things that are important for you, what are the things that you really want to avoid. A lot of people talk about birth plans. We don't usually talk about birth plans too much because you can't plan birth, but it is nice to have a good sense of like what are the things that are more important for you and why, and to make sure that your team is aware of that and is ready to advocate for those things and to remind you of those things, because a lot of times when you're in labor, you're just somewhere else and you have to kind of be focused on what's happening right here in your body, and you just forget of all these little things that you had thought about before. So that's when having other people there that are really ready to remind you of those things and to ask you questions and to help you feel safe can be so important.
Okay, so these are just a couple of tools that you can use while you are in labor and in the hospital as check-ins and to continue to have informed consent throughout the process. So one exercise we like to call, one exercise that we call going inward. And the idea with this is really just to slow down. It is super rare that a true emergency happens where things are moving really, really fast and you don't have time to think anything through. And so this is a great opportunity to just pause and check in with yourself. And we break it down into these 4 directions or avenues from which we can gather information, right? So we have our head. So you can check in. What am I telling myself? How am I talking to myself? Is what I'm saying over and over, this sucks. I can't do this. I want it to be done. Is that what's happening in my inner monologue? Check in with your body, right? So often, we're so fearful of the sensation of contractions that we're not even contracting. Actually, in the moment, we don't feel any physical discomfort, but we're so nervous for what's ahead. We're sitting there like this, all crunched up because we're anticipating what's to come, instead of checking in and saying, oh, wait, I don't feel any discomfort right now. I have a break. Let me lean into this break and take this rest a little bit so that I have more energy when the contraction does come back. And check in with your emotions, particularly for those assigned female at birth. We've been taught that we're crazy and to mistrust our emotions, but oftentimes what's happening in our emotional life is giving us really important information about what's happening internally with us overall. Are we feeling afraid? Are we feeling embarrassed? Are we feeling joyful? And really, sometimes the greatest way to shift and release that emotion and enter into a new space is just to share how you're feeling. Remembering that you have brought people into the room with you for your labor that you hopefully trust, that can help get you out of there if you are feeling afraid, can help make suggestions, so that can start to dissipate and shift a little bit. And then checking in with your gut. And this one's the hardest one for me. That's just remembering that we are connected to something bigger and greater than ourselves. We are connected to all the birthing people that came before us. As extraordinary as labor and birth is, it is actually super ordinary. And that sometimes it's nice to remember those that came before us that have been doing this forever and forever. And that, for the things we have no control, we must let go, because there's nothing we could do about it anyway. So just kind of doing that internal check with your 4 directions on there, and then communicating with your support team in the places where you feel stuck so that you can get support and can continue through. As you always say, the only way out is through. So
yeah, cool. So then the next thing, I love this one, we call it the self-exam. And so if you're birthing in a hospital, typically what happens is throughout labor, the doctor or the nurse, usually the doctor, the midwife, or someone from the medical team is going to come by your room and do cervical vaginal exams to see how far along you are, how much dilation has happened, how much your cervix has changed, are you aphased, etc. So what we always say, like a lot of times what happens is like you come in, you are at a certain number, then a few hours of, a lot of hard work go by, and they come in again and they check you, and the numbers are the same. And that can be such a, tough position to be in, because you're so frustrated, because you're like working so hard and nothing has changed, and what's going on, what's wrong, something's not working. And it's very easy to kind of like get in your head and then just like worry too much about what's going on based on those numbers, and not be able to just like let kind of labor happen the way it needs to happen. And so we introduced the self-exam, which is with every physical exam, as a way to kind of going away from those numbers and that information that really is for the doctors and for the medical team. It's not for you necessarily. um, the self-exam is a way for you to check in with yourself and see like, okay, maybe the numbers are the same, or maybe actually they changed, but how do I feel? Are my contractions feeling different than they felt the last time they did an exam? Are they stronger? Are they lasting longer? Are they coming closer together? Are they slowing down? Do I feel pressure in different parts of my body? Has my emotional state shifted? Are we seeing more blood, more fluids, less blood? Do I need to rest? What is going on? And that self exam can be even more important than the exam that the doctor is doing, because it really speaks to kind of where you are and what's happening in your body, aside from the fact that what they're measuring is a number that gives them information on what they think might be the next right step, or if an intervention is needed, etc. And of course they're gonna, talk to you about all that. But if you're doing a self-exam, then you have all this other information about yourself and where you are, that can be like a big piece of the puzzle.
Yeah, and the one thing I just want to add to that is the reason why the numbers are somewhat less important is because the numbers don't tell you what is to come, right? We've seen people go from no exaggeration, 3 centimeters to 10 centimeters in 45 minutes. And we've seen people be at 8 centimeters for 3 hours. So all that information is giving you is where you are at in that moment. And it truly, truly doesn't speak to what's to come. And so therein lies the problem with the numbers, right? As we get wrapped up in, oh my gosh, like there's no change, or you feel like you're in active labor and you get your first cervical exam and you're told, oh, you're not even in active labor yet. You're only 3 centimeters, right? Like that's exactly what you want to hear. So I think it's just really important to remember that change can happen quite quickly. And so we want to do what we can to support that change happening, which means getting out of our heads and into our bodies and not feeling stressed out about those changes. And so, you know, understanding that, okay, like maybe I haven't felt, maybe my numbers are exactly the same, but like I just got to sleep for the last hour and now I have some energy as my contractions slowed down. So I got some rest and now I have some energy to keep going. So it's just a different framework for you to kind of to consider.
I just
And the
want to
other thing I
quickly.
will say is sorry to interrupt you, and
Go
this
ahead.
is just like a marker for yourself, is oftentimes when you are getting a physical exam, they'll only tell you your dilation. And there's actually 3 key indicators that we're looking for that give a much more well-rounded um, picture of what's happening. So you have dilation, which is, the up to 10 centimeters. And then you have station, which is how high or low in the pelvis your baby is sitting. That's measured between +5 and -5. Some people do +4, -4. But the idea is, the negative numbers means baby is floating higher in the pelvis, and the positive numbers, baby's closer to crowning. And then lastly, yeah, if you can see, yeah. And then lastly, we have effacement, which is how thin the cervix is. And that's measured in a percentage up to 100%. So, the closer you get to 100%, think of like a lifesaver that you suck on. And it gets thinner as like the hole gets wider and the perimeter gets thinner. That's what's happening to your cervix. So you always want to ask about effacement and station if you're only being told dilation as well. Okay,
Yeah,
let's
and then
keep.
I just want to quickly answer Sophia's question about refusing cervical exams altogether,
Yeah.
which you can absolutely do. You can refuse cervical exams if you don't feel comfortable with them or you don't want to know. Um, I would say that is something to talk about with your team beforehand, so that you have that conversation while you're not in labor, and you make sure that they're comfortable with that and that you have a plan for what that means. And then I would also say, if the reason why you want to refuse cervical exams is because you don't want to know the numbers, because you don't want those numbers to potentially mess up your head, or kind of where you're at, you can also, as an option, is to kind of let them do the cervical exam, but ask them not to share any information with you. Some people really like that, and it's a way to kind of compromise that can be helpful.
Cool.
Okay,
Okay.
so go ahead.
I was going to say, we're going to give you 2 more tools, and we want to make sure we have time for questions. So we're going to go quickly through this part.
Okay,
So go ahead.
I'll do it. So this one is an acronym that is easy to remember. It's called BRAND. So if your provider is um, recommending intervention or recommending a next step, and you're not really kind of sure where to go, this is a good acronym to remember. You want to ask B, what are the benefits? R, what are the risks? A, what are the alternatives? N, what happens if I do nothing? And D, do we have time to decide? Is this an emergency, or do we have time to think about this? And I just want to say, we didn't come up with this. This is something that's kind of like been in the birthing community for a long time.
Yes. Yes. And then lastly, we have the 5-minute rule. And this, as a reminder, again, it's very rare that we have true emergencies that need to be dealt with like this. Oftentimes you have time. And so the 5-minute rule, just as a reminder that you can always ask for time alone without anyone in the room. Because sometimes, when you have your clinician sitting there waiting for you to respond, you can feel like there's a lot of pressure, and you don't have time to think through, wait, do I want this? What are my questions? Are there things I should be considering? So you can always just ask for 5 minutes alone, and then use that time to make sure that you don't have any questions, that you're, touch base with your partner, touch base with your doula. Even if you know that you are totally on board with whatever your practitioner is recommending, totally on the same page, just slowing down and taking that time to confirm that you are on board is one of the greatest tools to prevent trauma later on, because at least then you can look back in your experience and say, at least I consented, I made the best decision that I could with the information that I had at the time. And that's really all we can do. And that's really the art and skill of labor, is trusting that and remembering that we don't have control of so much, and that all we can do at any given moment is make the best decision that we can with the information that we have.
And then just lastly, a note to be prepared and think about that you might have to advocate for yourself and your baby postpartum too. Typically, you stay in the hospital 1 or 2 nights, or maybe even 3 after baby's born. And so, a lot is happening during those couple nights. You're, obviously getting ready, meeting your baby, but also meeting your new body. And so you might have to advocate to keep your baby with you at all times if that's what you want to do, or to take them to the nursery. You might have to advocate to get body feeding help if that's part of your plan. There's a lot of things that are still happening that you want to plan for. And again, get clear on what you think you're going to want, and talk to your team about it. Talk to your partner if they're going to be there, and be ready to have those conversations and advocate.
Yeah. And just to piggyback off of that, when you're home too, unfortunately, in America, most of us don't see our care providers for 6 weeks postpartum. And that's a lot of time, for things to happen. And so just, continue those skills of tuning in that you used in labor. And if at any point you feel like something is off, you're bleeding too much, trust that and check in.
Mm-hmm. Okay, so now we're kind of shifting a little bit about thinking about common interventions. We know this is a big concern for a lot of people. What are the interventions? How do I avoid them? If I get one, do I need to get them all? So this is just a little intro to kind of give you some I guess food for thought to consider these two ways about thinking about interventions. And the first one is, what are the what are the interventions that that you want? And then the second one is, what are the interventions that you only want if they're necessary? So the difference there, you might already know that you want an epidural, or you might already know that you're going to need surgery, or you might already know that you're going to be induced. And those are things that you're choosing, that you've thought about, that you've made a decision to go with. Those are things that you already kind of like are going in knowing that are going to happen. And then there might be some interventions that um, you know that potentially you could need, but that you really want to avoid. And so what are those, and why are they so important for you? And instead of kind of thinking about them as interventions that you really want to avoid, maybe leaning into interventions that you're open to having if they become necessary, but only if they're necessary. It's like a way of thinking about them that can be more helpful. And again, very important that you share this with the team and whoever's going to be there with you, so that they're aware of this.
Mm-hmm. Cool. Okay, so just a quick couple of things just to know about interventions, and just the reason why we want to change the language from interventions I want to avoid to interventions I'm open to if necessary is because it kind of puts a hierarchy on the fact that interventions are bad. And that isn't true. Interventions can be life-saving. The issue is just when they're used without consent, that right, and or improperly or overused, right, and or when a client isn't being, it's not client-centered care, individualized care, and it becomes just part of the routine. So just some things to know about interventions overall is first that many interventions come with other interventions. So for example, if you're someone who knows they want to get an epidural, it's helpful to recognize that not only are you getting the epidural in your spine, but you're also getting a catheter, you're also getting a blood pressure cuff, you're also going to have a pulsometer on your finger, you're also going to have an IV bag. And this is all for your safety of this specific intervention, but sometimes, because we just don't know until we know, it can feel a little off-putting, or like you're ET or someone with, all the wires and stuff. So it's just nice to go into it knowing what to expect. The next thing is that while interventions don't always lead to other interventions, they do usually increase your chances of needing them. And so, for example, or stick with the epidural because it's a popular one. You get an epidural, that doesn't mean that you're going to necessarily need Pitocin to help speed up your contractions, but it does increase your likelihood that you will need Pitocin. And, it's just something to think about overall, that like once you're on the intervention train, it becomes harder to use natural, or for lack of a better word, to use alternative practices. It's not that you can't, it just becomes you're moving into pharmacology, where now we're really relying on the skills and knowledge of the practitioner who understand pharmacology to understand everything else that's happening, right? We're kind of moving out of our expertise a little bit. So yeah, and then the last one is just that interventions can actually help you avoid a C-section. So for those, again, this isn't to create a hierarchy that C-sections are bad. It's just for those, and this is just a pattern we see a lot in our practice, of people who really don't want to have a C-section. And so this is just to say that, we've seen plenty of people get the epidural, and that was the thing that allowed their cervix to open, and they had a vaginal birth with no complications. So it goes in both ways. In the same way that it can increase your chances of needing other interventions, it can also help you achieve your birth.
Mm-hmm. Cool. Okay, so just a couple tips. If for those who want to avoid potential unnecessary interventions, if that's a concern to you, the biggest thing that we always recommend, and it's funny because a lot of providers like doctors or midwives recommend this as well, is to stay at home as long as you can. And that can be tricky to even understand what that means if this is your first time, being in labor, and especially if you're not working with a doula that can kind of guide you through, what's normal and what's a good time to go to the hospital. So it's something that is important to kind of like think about beforehand, talk to your doctor about it, and some just tips for you to know that it might be too soon to go to a hospital. So if you can still talk through your contractions, if you can sit down and have a meal, if you can be on social media, talking to friends or family on the phone, if you can get in the car without needing to stop for contractions on your way. This just makes me laugh because so many times, being a doula, like it takes like 15 contractions before you're able to get someone from like the couch to the door into the car, because they're really in active labor, and that's just the pace that they can go through, and that's what we're doing. And usually, if you're in active labor, you're going to be needing to like stop to like have the contraction where you are. Once the contraction starts, you cannot move, and then it might take you a while to get to your car. If you can just walk like you normally do, it's probably a little too soon to go to the hospital. But all this being said, if at any point you feel like I just don't feel safe at home anymore, or I can just I need to be in the hospital, or something feels off, I really want to go, then obviously it's time to go no matter what. So always trust that. And then the last one was to just a reminder to remain an active participant in your labor, like Ash was talking about before.
Yeah. So this is just like a new way that interventions can be used. So intervention is recommended because the pregnant person is asking for it, or because of the pregnant person's unique and particular labor, not simply because of policies or protocols. The pregnant person's body or gut is telling them that the intervention is truly functioning as a tool for their and or their baby's safety or ability to keep going. The pregnant person or their medical proxy understands the full risks and benefits of the intervention and consents to its use prior to it being administered. This goes for all interventions, even those that come in packages or are needed because of previous interventions introduced. All right. Woo! A lot of information.
Yep. Okay, so we'll just answer some questions. I know we ended up talking for a little bit more than we had planned to. There's always just so much to go through. So we can, if people can stick around for a little longer, we can add a few more minutes to answer as many questions as we can. But I just want to kind of like tell everybody. So people had asked if we could share our slides. The answer is yes. And if this recording is going to be shared, then the answer is yes too. Hatch should send everybody that sign up an email with all the information tomorrow or later in this week. So just look out for that. Okay, should we start, Ash? So the first question that came through and just a reminder to add your questions through the Q&A box. That makes it a little bit easier to answer them. So Ashley is telling us that she was diagnosed with preeclampsia last week, and she's struggling with trusting her provider as she's been in and out of labor and delivery twice in 7 days due to high blood pressures. I see all 9 doctors in the practice and all have differing opinions on how to manage my case. Should I look to change my provider this late in the game? Oh, that's a tough question for us to answer. I would definitely say, like, do you feel that you need to change providers, and what are your options in that sense? Have you been able to look around and what that would look like? If you've been diagnosed with preeclampsia, I don't know, you're not telling us how many weeks you are, but I am a little surprised that they're not keeping you in the hospital. If you can share how many weeks you are, that might be helpful in terms of answering this question. Typically, once you're diagnosed with preeclampsia, they want to keep you in the hospital, really watching that high blood pressure, and eventually, if things don't resolve, you might need to be induced because really you're 35 weeks. The sort of like the cure for preeclampsia is for baby to be born. So a lot of times we see that when people are diagnosed with preeclampsia, the treatment is to really get the baby out. But this, I think, applies no matter your situation, for everybody. If you're not really trusting your care providers, that's just such a tough position to be in. And if you're looking at potentially being induced or spending more time in the hospital, um, you know it can be really tricky. I would say, even if it feels like impossible and overwhelming, we've definitely seen people switch providers at the last minute, 30, 40 weeks. It sounds crazy, and maybe it can be stressful and be a lot of work, but if that's what you feel that you need to do, then go for it, because it might be possible.
Yeah, and I'd say, well, first off, I'm really sorry that this has been your experience. I know it's probably just what you need right now, on top of everything else happening in the world and, being 35 weeks pregnant. So, just, I know that it isn't easy. So sending you lots of love and hugs and virtual hugs. But I'd say that, if there is, I just want to add to, if you are getting different opinions, if there feel more in line with their recommendations. There's a great website called Evidence-Based Birth that I would highly recommend reading their article on preeclampsia there, just so you have some, research and data to support. A lot of this will depend on your other medical history as well, which obviously we're not clinicians, we aren't privy to that information. So there may be a part of the story that, we can't speak to. But that's a great question to ask, right? Like, does anything else in my medical history make it so that you are recommending this? And, while obviously only one of your providers will end up at your birth if you choose to stick with them, if you come to a plan with one of the providers whose advice you do trust or that resonates with you most, then, you can make a plan with that provider and have them ensure that all the other providers are on board with that, no matter who ends up managing your case.
Okay. Have any patient rights changed with the onset of COVID-19? I am not aware of anything changing. I know there's more restrictions in some hospitals in terms of like the number of people that can be with you in the room, restrictions of how, going in and out of your room for yourself, but also like the people that are with you, restrictions obviously about like wearing masks and protective equipment and things like that, restrictions of like what happens if you test positive for COVID, or if your baby were to test positive for COVID. There's different protocols that different hospitals have for that. But in terms of your rights, as it relates to what we were talking about before, they should be, you still have the same rights.
Yeah, and just, it's their policies that are changing, right? And there's a difference between your rights and hospital policy. It's going to be very different at different hospitals and is potentially changing week to week. So just keep that conversation open. Call your hospital, ask them what their policies are around COVID, ask them, what are your separation policies? Is any, who's allowed to stay with me for how long, et cetera. So just make sure so you know what to expect.
Okay, would love to learn more about what we can ask about options to consider once the baby has arrived while we're in the hospital. Do you want to answer that, Ash?
Sure. I'm not
I think she's talking about, what are the different options that are available once baby's born. So, things like keeping baby with you in the room versus sending baby to the nursery and only having baby with you while they're feeding, giving baby a bath, giving things like if you have a boy or a baby with a penis, some people choose to do the
Circumcision.
circumcision. Thank you. Things like that.
Got it. Yeah, I mean, those are some of the big ones, right? And you can just quickly list off. So giving the baby a bath, can totally refuse to have them give your baby a bath if you don't want them to bathe the baby, bathe the baby. Generally, non-COVID times, you know, you have the right to have your baby with you all the time. They never have to go to nursery. That's a great thing to clarify with your hospital ahead of time if they are doing separation, if anyone tests positive. And then I'd say the other big one is if for some reason you and baby do need to be separated and you're planning on body feeding, that you can use a spoon or a little cup or a syringe to collect your colostrum and feed it to baby that way instead of supplementing the formula or introducing a bottle or like a false nipple that may interfere with feeding later on.
I just want to say that at the beginning of the pandemic, hospitals were based on a recommendation by the CDC, were separating parents from babies if the parent tested positive. But lately, the recommendation changed. The CDC updated their recommendation maybe a month or more. You know, maybe it's been already 2 months since it was updated, and the American Academy of Pediatricians, followed the recommendation saying that even if the parent is positive, the recommendation is to keep the baby together with the parent. And there might be some protocols that you have to follow in terms of like wearing masks and obviously washing hands and things like that. But the recommendation as of now is that baby and parent should stay together.
Yeah, and that's the CDC is a great resource because sometimes hospital policies, they're like not up to date with the CDC guidelines, right? Like as they're changing rapidly. And so if, for example, you're getting pushback for that, you can show them the CDC guidelines as your data point.
Right.
Okay. Next.
Okay. Isis wants to know, stay home as long as you can. Are these still good rules of thumb when you're 90 minutes away from the hospital? If not, what indicators will you recommend being aware of? Yeah, that's a great question because obviously, yeah, you do want to consider your commute and how long that will take. But so, this depends, but I would say some of the things that we always tell people when we teach childbirth education is the signs that you are in active labor are typically your contractions are, let's say 3-1-1, which means they're 3 minutes apart. They last for at least a minute or more, and they've been like that for at least an hour. So 3-1-1. It's a good way to remember that. So that basically just comes down to pattern of the contraction. The other good indication that you're in active labor is that you're starting to see blood. We call that bloody show, and it looks like a period blood. Obviously, you don't want to see tons and tons of blood, but just so you're not worried if it happens, bloody show is like, it's a good amount of blood, and it's like red, like your period blood in the first couple days tends to be. So bloody show, a 3-1-1 contraction pattern. And the last one is pressure in your butt. Pressure like you have to go poop. That's a good indicator that baby is low enough in the pelvis and that they're starting to put pressure in your rectum and that, you're kind of getting closer to having to push. If this is not your first baby and you had a quick labor beforehand, but even if you didn't have a quick labor beforehand, these things, the way you make this decision might change. So really talk to your provider, because a lot of times after you've had a vaginal birth, the second or, any births after that can be quicker. So just keep that in mind if this is not your first.
Those are definitely not the guidelines if this is not your first baby, particularly if you are an hour and a half away. So so if it's not your first baby, and if Isis, if you know that you want an epidural, that's your preference, you probably don't want to wait that long either. Just because it could take some time to actually get the epidural once you're in the hospital, get your IV, etc. So that's just something to consider too. But having a doula might be helpful for that for you if you have one.
Okay, Erica wants to talk about the walk-in epidurals and how it impacts changes the cascade of interventions. So the one thing I would say about the walk-in epidural is that does not exist. They call it a walk-in epidural, but they never let you walk. You are rarely, very rarely, I mean, I can think of one labor in the hundreds of labors that I've seen of somebody that was even allowed to get out of the bed. Typically, if you have an epidural, they want you in the bed and they don't want you walking around a lot. So that's something that's a little misleading because we do hear that a lot. Anesthesiologists love talking about walking epidurals, but they don't really let you walk.
No, I've never seen anyone,
Yeah.
So
Yeah.
It's more so that the cocktail, if you will, of medications in the epidural has changed drastically since they were first introduced and since the 80s. And so it's just a different experience. It used to be that, you had dead legs, you couldn't feel anything from the waist down, and some people still experience epidurals that way. But for the most part, you can still feel, lots of people can still like feel the pushing, that like pressure in their butt sensation when it's time to push. Some people can still move their legs. They can still switch positions in the bed. So they do have some mobility. It's just you're not getting up and walking. And to answer your question, all the cascade of interventions that we talked about is for any form of epidural.
Okay. So Stephanie wants to know what are the terms that I should use and things I should tell my doctor to make it natural unmedicated birth in a hospital setting. I'm afraid there's no kind of magic answer for that. There's no like one thing that you can tell your doctor, but I would say a lot of people do birth plans, and again, we don't really typically recommend that, but I would say, and actually if you have our book, we do include some questions in our book of things that you should ask your care providers, because it is very important that you understand what, if you are induced or if you decide to have an epidural, what comes with every intervention, and what is the process of induction that your doctor usually follows. What happens, like the walk-in epidural is a great example. Like, is there walking with an epidural? All these things that you should be able to, or that you should be talking to your doctors or your care team before labor, so that you have time to have those conversations beforehand, and so that you don't have to so much during labor, but so that you have a clear picture of what to expect, and so that they know what your expectations or your hopes for labor are, and they can kind of manage those expectations. Our midwife friend always says, like, you can't go to, it's something like this, I'm paraphrasing, you can't go to a Chinese restaurant and order a pizza. Like, they're gonna make the pizza for you, maybe if they're nice, but the pizza is not going to be like good at all, right? So like, you really want to know like what are the things that are possible, and just have the right expectations so you're not disappointed when you're in labor. And so having those conversations now with your doctor as it relates to what your preferences are and the questions that you have is very, very important.
Yeah. And, it's certainly possible. We've had plenty of clients have unmedicated births in hospitals for sure.
Cool. Okay,
so let's
Stephanie,
do one last question.
Huh?
This will be our last question.
Okay. I was just going to say that Stephanie asked about COVID, but we already covered that, so I'm going to skip it. There is, does placement of the placenta increase the chances of interventions like needing to be induced? I have an anterior placenta. And I would say no. Some people say that if you have an anterior placenta, and for those who don't know that, the anterior placenta is usually just kind of like on the top of your belly versus like up here where it would be, or where it, I guess, more commonly is located. And so some people say that if you have an anterior placenta, there's more possibilities of the baby being posterior, which means that instead of facing their face or their body being facing towards your back, they're facing towards the front. And sometimes if your baby is posterior, labor can just take a little bit longer, or maybe be a little bit different because it just takes a longer time for baby to rotate. But that being said, there really is no evidence or any difference if your placenta is anterior. I actually had an anterior placenta, and didn't, nothing happened because of it. Right, Ash?
Yes, I was there.
You were there.
All right. Well, thank you everyone so much. We will be here next month again. I think, no, January is our next one, right? Nat? January.
January.
Yeah. So we'll be back in January. Our information I'm going to put in the chat again. It's why did
Actually, December 1st. Sorry.
.com. Oh, December 1st. So we'll be back in a month. You can answer more of your questions. As Nat shared in the beginning, we are taking some digital doula clients right now, and we take you together, and we created this new format because of COVID. Knowing that people were having trouble having doulas in the hospital, knowing that, some people don't know if they want a doula, they just maybe want to be with their partner. And so it's all virtual. You get the support of both of us, and it's basically, we'll be there alongside of you if you have questions at any point. Interventions being recommended and you don't know the questions to ask, you want more personalized assessment of your unique situation. And within our doula services, we also do a full childbirth education course. And we do it as a small little group. We cap at 4 couples, and that way you all have like a little community of each other that you can check in with who are around the same stage, and learn from one another as well. Did I miss anything?
Yeah, no, I was just gonna add that we are on. Somebody was asking if we were on social media. We are on Instagram, and you can find us as Our Brilliant Bodies. And so, we didn't get to your question, and you really want to know something, just feel free to reach out to us via our Instagram, and we'll just be in touch. And then as I said, Hat will send an email to everybody with the recording of tonight and some of our notes. So just be on the lookout for that. And good luck, everybody. Happy birthday and have a nice fall. And it was really nice being here with you all tonight.
Yes. And Isis and anyone else who wants to sign up, it's ourbrilliantbodies@gmail.com is our email.
Yes.
Good night, everybody.
Bye, everybody.